Welcome to an NRG Oncology podcast from the 2026 annual meeting of the American Society of Clinical Oncology. We're back in Chicago at ASCO by popular demand, covering the most high-profile NRG oncology studies being presented at ASCO this year. Today, we're excited to talk about the mature results from NRG Oncology GY018 for advanced or recurrent endometrial cancer. Our guest today is its principal investigator, Dr. Ramez Eskander, who is a professor of gynecologic oncology at the University of California, San Diego Moores Cancer Center. Dr. Eskander, welcome to the NRG Oncology podcast and congratulations on this landmark study. Previously, you presented results of NRG Oncology GY018, looking at the role of the immune checkpoint inhibitor pembrolizumab for advanced recurrent endometrial cancers. Before we get into the results presented today, what was the design of NRG Oncology 018? What information is out there that's already been presented before?
Well, thank you, Dr. Chen. Thank you for inviting me. I'm excited to be able to share this information. As you alluded to, NRG-GY018 was a clinical trial whose primary efficacy endpoint was read out in March of 2023, and it was simultaneously presented and published. And this trial, design-wise, was a randomized phase 3 clinical trial that examined the addition of pembrolizumab to carboplatin and paclitaxel, followed by pembrolizumab maintenance for a total of up to 2 years of therapy, versus a placebo plus carboplatin and paclitaxel, followed by placebo maintenance. And this was in a patient population with advanced stage, recurrent, or metastatic endometrial cancer. If patients had stage 3 disease, they were obligated to have residual disease on imaging after surgical resection. If they had stage 4B or recurrent disease, they were allowed to enroll irrespective of the presence of radiographically measurable disease as long as it was evaluable. These patients had an ECOG performance status of 0, 1, or 2, and they were permitted to have prior adjuvant chemotherapy as long as they had a 12-month chemotherapy-free interval. And what's really unique about the design of this trial, which sometimes gets overlooked, is this was really 2 clinical trials in one. We understood the efficacy of immune checkpoints in mismatch repair deficient cancers, we'll call it dMMR cancers, and we knew that that was differentiated from the response in mismatch repair proficient or pMMR cancers. So this trial was designed to ask about the therapeutic benefit of adding pembrolizumab to chemotherapy in both the mismatch repair deficient population as well as the mismatch repair proficient population. Each of those was powered independently with its own statistical assumptions and hypothesis. In March of 2023, we shared this, what we would consider really landmark data, because in the mismatch repair deficient population, the addition of pembrolizumab to chemotherapy resulted in a 70% reduction in the risk of disease progression or death. And provocatively, in the mismatch repair proficient population, it was a 46% reduction with respect to progression-free survival.
With all of that out of the way, I want to get to the meat of what was presented today at ASCO 2026. What is new in 2026 from GY018? Were there any surprises in this mature data that were not apparent in the initial report of GY018?
This data is important because it's looking at much more mature overall survival data. When the initial trial read out, the overall survival data was understandably immature because the study met its primary PFS endpoint at interim analysis. So this data that was shared is focused on the updated overall survival. In the mismatch repair deficient population, now with an information fraction, 43%, and a median follow-up of 49 months, what we saw was the addition of pembrolizumab to chemotherapy had a hazard ratio of 0.56 when compared to placebo plus chemotherapy. So a really substantial and significant reduction in the risk of death. And what I want to highlight is that this benefit persisted in the context of 93% of patients in the control arm receiving immune checkpoint inhibition if they receive subsequent therapy. That, in my mind, is what's provocative about this data, which is even in those patients in the control arm, in the dMMR population, who were initially treated with placebo, The vast majority of those, 93%, had post-study checkpoint, but the hazard ratio of survival is 0.56, favoring pembrolizumab and really emphasizing the importance of early utilization because you were unable to rescue every one of these patients who progresses with subsequent checkpoint. And similarly, in the mismatch repair proficient population, here again, a much larger, much more mature data, 82% information fraction in the mismatch repair proficient population, median follow-up of 44 months. 81% of the patients in the control arm who reported receiving post-study therapy had post-study immune checkpoint. And despite that, again, the hazard ratio for survival favored the pembrolizumab containing arm of the trial with a hazard ratio of 0.86. This adds great confidence to an already approved FDA regimen, but really highlights, in my mind, the value of utilizing this as early on in the treatment paradigm based on the FDA approved indication, because we recognize that this benefit is there, and we recognize that even with substantial post-study checkpoint use, we don't abrogate that delta, that difference in benefit.
I wanted to just focus on that a little bit and perhaps explain it in simpler terms. This is a very profound finding that, in spite of the majority of patients getting salvage immunotherapy, it did not make up for not having gotten immunotherapy or pembrolizumab in the first place. I want to ask, is it fair to say that waiting for the tumor to come back before pembrolizumab can't make up for not getting it in the first place? And biologically, why do you think pembrolizumab is more effective when given earlier rather than later in these patients?
This is such an important question, Dr. Chun, and thank you for asking. I do agree with you completely. Of all the randomized phase 3 trials that looked at this therapeutic intervention, because so many of the patients in the control arm received post-study immune checkpoint inhibition, and we knew that would be the case because unblinding was built into the trial, as we alluded to, this data strongly argues that using immunotherapy in the beginning in combination with chemotherapy is the preferred strategy, because waiting to sequence it does not allow those patients to have the same oncologic outcome as it relates to overall survival. And the biologic rationale, it's complex, and we have not elucidated this. So this is just my hypothesis. We know in the treatment of solid tumors that as cancers progress on therapy or recur after exposure to a cytotoxic drug, there is a selection pressure. We're working essentially in an environment where we have cancer cells that survive in exposure. And in doing so, they're adapting, they're evolving, they're acquiring resistance mechanisms that aren't very clearly understood and are likely multifactorial. What we may be seeing is if we use immunotherapy, immune checkpoint inhibition with chemo early in the treatment paradigm, here again in patients with advanced stage or recurrent disease, we may be enriching our ability to achieve long-term remissions or potentially cures. And if we wait until they recur, the biology of the disease may evolve to where we lose that therapeutic opportunity. And that's why we don't see the overall survival curves come together at the tail, even though there is substantial post-study ICI in the control group.
Another aspect of the study I wanted to focus on, and I want to focus on it because it's a concept that transcends multiple kinds of cancers like endometrial, ovarian, even colorectal cancers. In GY018, you specifically looked at responses to pembrolizumab based upon what you described, whether the tumor had proficient or deficient mismatch repair. In other words, did the cancer cells have the ability to repair damage of their DNA or not? Can you explain what exactly mismatch repair is and why mismatch repair proficient versus deficient tumors respond differently to immunotherapy?
This is an important concept that tied directly into the way the trial was designed. We've known for quite a while now, almost a decade, that cancers that are mismatch repair deficient are sensitive to immune checkpoint inhibition to a different degree than those that are mismatch repair proficient. The hypothesis being that we have these sequences in the DNA that are these repeats that happen over and over. And during replication, because there are these duplications, there can be errors in our cell's machinery in reading that DNA. And those errors can result in mutations. And those mutations can be recognized as foreign by our immune cells, just like our immune cells recognize bacteria or viruses as foreign. So if you have cancer cells that are deficient in mismatch repair, they're going to be ineffective at repairing those errors during replication or cell division. They produce these mutations, and the greater the number of these mutations, this mutational burden is the tumor that we use, the more recognizable those cancers will be to the immune system as foreign, allowing us to take advantage of a therapeutic strategy like an immune checkpoint inhibitor. And as some of us may recall, the very first disease site agnostic drug approval in oncology was pembrolizumab in mismatch repair deficient recurrent metastatic solid tumors. So we knew that checkpoint was more effective in mismatch repair deficient malignancies. We had FDA approvals in that indication in a disease agnostic manner, meaning looking at the biomarker rather than where the cancer emerged. And we had data from phase 2 trials that showed that single agent immune checkpoint in mismatch repair proficient endometrial cancer had much more modest response rates on the order of 6 to 10 or 12%. And so all of that data together speaks towards the rationale for why the study was designed the way it was, why the hazard ratio in the dMMR population of NRG-GY018 was 0.30 for the primary efficacy endpoint, but it also highlights the rationale for why we put cytotoxic chemotherapy with immune checkpoint in the mismatch repair proficient, because we're trying to drive more immunogenicity to get that response.
You had mentioned that based upon prior findings of NRG Oncology GY018, the FDA had already approved pembrolizumab for these advanced or recurrent endometrial cancers, and that was regardless of the mismatch repair profile. Do you get the sense that pembrolizumab has already been accepted as standard of care in this population? And with these mature results presented today, do you get the sense that there will be further practice-changing implications?
We took an important step when this regimen was approved for use by the FDA, and since then, outside of the United States, by the EMA and in other countries. I will say the reason that I find this data to be important is, yes, there has been utilization of chemotherapy plus pembrolizumab with pembrolizumab maintenance in the mismatch repair deficient and proficient patients who are aligned with the eligibility criteria of the trial. But in the same breath, there was also a hunger, particularly in the mismatch repair proficient population, to say, well, is there a biomarker? Can we figure out who would benefit? And there was also a narrative that, well, maybe we don't use immunotherapy with chemo early on because we have the opportunity for lenvatinib and pembrolizumab after carboplatin and paclitaxel. And so the reason the overall survival data that's more mature in my mind is provocative is, as we discussed previously, we're showing that even in the instances where the patients on the placebo received post-study checkpoint, and to clarify, if you look at the mismatch repair proficient cohort, we actually looked at all of these patients and their subsequent treatments. Nearly 60% of the post-study ICI in the mismatch repair proficient was lenvatinib and pembrolizumab. Again, the hazard ratio of 0.86, those curves don't come together. So this is where I feel like the impact on clinical practice is we have the FDA approval. This adds great confidence to that FDA approval, and it also argues that we should be using this as early as we can in the therapeutic treatment paradigm because we want to maximize the clinical benefit. And we recognize from this data that waiting to use checkpoint in combination later in lines of therapy may not achieve that goal.
It's interesting that the timing suggests that we should be giving this treatment paradigm earlier and earlier. What do you think about a new NRG oncology concept testing this regimen in the neoadjuvant setting for these advanced endometrial cancers?
I would love a study to look at that. Interestingly, actually, I will say there have been concepts that have been proposed looking at incorporating this in the neoadjuvant setting. We are seeing more patients with endometrial cancer. This is not just a United States national issue. This is actually reported internationally. It's reported by our colleagues across the globe. We're seeing more endometrial cancer patients presenting with advanced stage disease that's not amenable to surgical resection. So we are extrapolating and using these regimens in the neoadjuvant setting, but wouldn't it be great for us to design a prospective trial to confirm our hypothesis that this is effective in the neoadjuvant setting? And perhaps more provocatively, Dr. Chun, is in the mismatch repair deficient population where you have such profound responses, Could using this in the neoadjuvant setting really transform the treatment algorithm altogether for these patients? And what is the role of surgery becomes a question, et cetera. It's hard to design, I'll give you that, but these are provocative questions that we're hungry to have an answer for.
That's so interesting. It reminds me of some of the work that's being done in the colorectal cancer space for immune checkpoint inhibitors. As always, with big NRG oncology trials, we like to give our principal investigators the opportunity to acknowledge the key players on the team. Who were the people you'd like to recognize who made GY018 a success?
As always with clinical trials, the very first individuals are the patients and their families who sacrifice, who are willing to enroll on a clinical trial when we know there's always some degree of uncertainty in a study. But it's their bravery and it's their humility and it's their commitment that ultimately allows us to conduct clinical trials that lead to an evolution in practice, just like NRG-GY018. I would also really like to thank Mike Sill, our statistician, who has really valiantly led the statistical design of this trial. And as I alluded to from the beginning, this was really two clinical trials in one. And that novel design has gotten a lot of credit. It was the only trial in the advanced stage and metastatic endometrial cancer setting that was designed in that way. And so I feel like it is the purest data in the DMMR and PMMR populations. Dr. Carol Agajanian, she's the Gynecologic Oncology Committee Chair from NRG. She's a friend, a mentor, and was critical to the conduct of the study. Important co-investigators, Dr. Fader, Welch, Dr. Wenzel, Heather Lanke's a translational scientist. I can go on and on. To be honest, I do feel obligated. The NRG oncology staff, Meg Colahan, Laura Reese, Antonelli, Ashley Batters, and then, of course, and without hesitation, our dear colleagues and collaborators for CTEP and NCIs. This was an NCI-sponsored cooperative group study. Elise Cohn, Meg Mooney, Larry Rubenstein, all of them were critical. And of course, I have to say, the partners at Merck. This was a trial that was conducted. It was sponsored by the NCI, but it was done in collaboration and in support with Merck. And so I really want to thank them for their contributions. And it was this totality that led to our successful ability to conduct this trial, report it out, and bring this medication to our patients.
Dr. Eskander, I want to just thank you again for coming on the NRG Oncology podcast today, and congratulations again on presenting this paradigm changing study that has undoubtedly already saved countless lives of endometrial cancer patients.
Thank you for having me. Appreciate it.
Today, we had Dr. Ramez Eskander, the principal investigator of NRG Oncology GY018, talking about findings presented at the American Society of Clinical Oncology 2026 annual meeting. You can follow the NRG Oncology podcast on the NRG Oncology webpage, or you can follow my Twitter handle at Stephen Chun MD or Lauren Henke at Lauren_Henke. The NRG Oncology Group is supported by grant funding from the National Institutes of Health, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.